Okay, starting the broadcast.
Hello, and welcome to the New York Mid-Atlantic Consortium for Genetics and Newborn Screening Services webinar series about timeliness in newborn screening. I am Dr. Scott Schoen, Program Manager for the Newborn Screening Laboratory in New Jersey, and I also chair the Newborn Screening Workgroup for NIMAC. It is my pleasure to moderate today's webinar, which is the second in this series. Today's webinar about pre-analytic timeliness will be presented by Allison Piques. Before I introduce Allie, I'd like to remind everyone that your lines will remain in listen-only mode. To ask a question, please type it in the chat box, and we will address each question at the end of the presentation. The webinar is being recorded, and a link will be provided after the webinar has been posted to our webpage. In addition, when the webinar ends, you will be provided with a link for an evaluation. We greatly appreciate you taking just a few short minutes to complete this evaluation. Allie Piques earned her undergraduate degree at Duke University. After trying her hand at pediatric oncology research, she realized she had a love for babies, not lab rats, and she earned her RN degree at Bon Secours College of Nursing in Richmond, Virginia. After gaining experience as a NICU nurse, she pursued a Master's of Science in Nursing, specializing as a neonatal nurse practitioner. She became interested in newborn screening through a graduate policy project to support the Newborn Screening Saves Lives Act of 2007. Allie works as a neonatal nurse practitioner at the Children's Hospital of Richmond, where she created a newborn screening task force to address system issues. She supervises the work group, which reports compliance data for NICU QA/QI works to educate medical and nursing staff, and audits internal transit time. I now hand this webinar over to Allie. Thank you.
Good afternoon, everybody. So welcome to my lecture today on timely screening for sick and preterm infants. I'm going to talk about a process improvement initiative that, though the title of this is Pre-Analytic Timeliness, I will give the disclaimer that this is actually going to be a little bit more about our journey in all aspects of timeliness in this special population. Any of the case examples that are included are just for a teaching tool. Names and photos have been changed to preserve privacy. And I also wanted to point out that any of the algorithms or protocols that are published here in this presentation are unit-specific and designed for our patient population in our teaching institution and not meant to be widely distributed. Having some trouble here advancing. So overall, starting with the problems that we were having here in the NICU when I arrived in 2012, from initially starting my career at Dartmouth-Hitchcock in New Hampshire, the newborn screening process in Virginia took a little bit getting used to, and that was a hard thing for me to wrap my brain around. It overall was a muddy process to me, and there were a lot of elements of variability of what I saw going on in the unit. I needed to find a niche, and this turned out to be what it was. So newborn screens in our NICU were historically obtained at inconsistent times, and it was a nurse-driven process. And when I talk about, things being nurse-driven, I'm talking about, when a baby's completely gone to full feeds, or when we can bundle labs, or I don't want to stick the baby now, and sort of standing orders. Any of you that have experience with NICU babies know that there are a plethora, a whole host of presumptive positives that we see, and there are generally standardized procedures to follow up on these results. And despite multiple repeat screens for our patients, it seemed to me and many of my colleagues that our babies remained at risk for loss to follow-up, and we're going to talk a little bit more about what that means. Why is this an issue? Well, we have very complex patients with acute on chronic needs, variability in practice, and of course, there are many factors involved in neonatal nursing and medical care that impact the results of newborn screens. Anything from antibiotics to blood transfusions to even the heat of an incubator or the use of heparinized blood samples, things like that. The use of chlorhexidine versus alcohol swab. These are the things that you have to start to think about when best practices start to interfere with other best practices. And the interpretation of these results as screens begin to expand becomes even more challenging. So the process improvement initiative, when we started to talk about it, I have to admit, it was a little bit overwhelming. You know, where do we even start? Well, luckily, our medical director was very interested in also undertaking this project. He had come from Maryland and wanted to kind of get his arms around it as well, and became sort of my co-chair of this task force, Dr. Russ Moores. We decided the first and most important thing was to standardize timing for newborn screens in the NICU. And one of the things we found out is that when you look to the literature and when you look to listservs and when you look to other hospitals and institutions, everybody's looking to do the same thing. And I quickly realized that looking to the state and looking to legislative code was not probably the best avenue. I just had pulled up the legislative code for Virginia. According to Legislative Code 12 VAC 5-71-70, for Virginia, if the newborn is a preterm infant, the specimen should be collected at 7 days of age. So we all now have the knowledge that that's probably not best practice at all. So, you know, it's hard to determine exactly best practice when even your most up-to-date guidelines that you're finding from multiple stakeholders may not be clinically based at all, and in fact could be detrimental. Number two, found that we needed to standardize follow-up procedures for abnormal and critical results. So in order to sort of illustrate some of the issues that come up on screens in the NICU, for those of you that haven't had the pleasure of that particular doom to repeat cycle, as we call it, the doom to repeat baby, when they get caught in the cycle of needing repeat after repeat screen. So this is baby girl repeat. Just a typical 33-weeker born in 2010. Now, mind you, that's before our newborn screening project was underway. Her newborn screening was drawn on day of life 6. But, unfortunately, she required a blood transfusion in the 2nd week of life. Her newborn screening results came back, and what do you know? Not too surprising that this premature infant would have an abnormal screen for CAH, or congenital adrenal hyperplasia, and those in the know say, what do we do about that? Does this child really have in excess of 17 OHP? Is she going to go into shock? Does she have signs and symptoms of congenital adrenal hyperplasia? Well, that's for the provider to figure out. However, within the newborn screening system, we need to make sure that we're able to close her case. We see that this baby is a healthy baby with normal electrolytes, but a second screen needs to be obtained because the first was abnormal. As you may have guessed, the second screen reflects a transfusion. But because the baby's adrenal axis has matured a bit, it is normal for her 17-OHP range, and so not presumptive positive for CAH. The lab requests a third screen, but it specifies that it shouldn't be until 8 weeks later, and that would give time for the transfused blood products to not be in her system. But what do you know? Baby girl repeat is ready for discharge before that time. So what's the provider to do? A, obtain a third newborn screen, hope it doesn't reflect a transfusion. B, assign accountability for follow-up to a community PCP. Or C, ignore the situation because baby girl repeat obviously doesn't have CAH, and that's what matters. Well, you know, it's a difficult question, and honestly, obviously we don't want to ignore any situation, but the reality is that there really was no great answer to this question, and we wanted to change that. The task force's main goals were to standardize the timing of newborn screening, like we talked about. We would audit timeliness, analyze factors related to mistiming, and identify why screens were being repeated. We wanted to develop a procedure for a consistent approach to follow-up on all newborn screening results. I think that this is particularly important when we talk about teaching institutions where you have maybe a migratory house staff, you have interns and residents. It may not be, you may not have the advantage of having the seasoned neonatologists or neonatal nurse practitioners that are used to seeing these labs and responding to them. Secondary goal, which we found was sort of hand in hand with achieving our primary goal, was to collaborate and communicate more effectively with the Virginia Department of Health. That was really crucial in being able to close the case in a timely manner. And we'll talk about what that entails. So what would the interventions be? Well, our unit has, I think, over 100 nurses strong, and in any place where you have that many staff, the obstacles are going to, include just the very element of changing the culture of newborn screening. We needed to develop a unit-specific protocol to meet the needs of our patient population. And what we found was this was very difficult to get rolling. Once we did, it became very successful, but we will talk about that when we talk a little bit more about our quality improvement data. We disseminated the protocol amongst providers and nursing staff, and educated staff about the new guidelines with an emphasis on team accountability for the newborn screen. And I think this piece is really important because there became, I think, as the newborn screening protocol or clinical algorithm there became more buy-in that was so hard to achieve. I think one of the components of that was an awareness of the urgency of this critical lab. I think it became much more than just another annoying thing that we had to do to our babies, but rather a possible life-saving intervention. And I think that was a really key factor we'll talk about. And finally, implemented our protocol. How did we get this protocol up off the ground? Well, we reviewed current practices, and like I said, I think I may have contacted, I can't even know how many NICUs and teaching institutions in the state, in other areas of the country and regions, and no one's doing the same thing. In fact, some of the responses that I would get was, well, tell us what you find out. And one of the most important pieces that documents, is the CLSI guidelines for sick and preterm infants. Reviewed that. I think one of the most important pieces for us here at CHOR was our interdisciplinary collaboration. We have the advantage of specialty consultants that were able to meet with us over a period of months to sort of hammer out the algorithm for follow-up. And we'll get to that in just a second here. So with neonatology, endocrine, genetics, metabolic dietitian, for medical nutrition therapy, pulmonology, our CF clinic, the lab scientists at DCLS, which is our state lab down the street, and then our newborn screening follow-up nursing staff at Virginia Department of Health. We were able to bring this off the ground. In 2013, we added a hemoglobin follow-up algorithm to our protocol, and then with the addition of FCID in 2015, we have a brand new allergist immunologist on board as a consultant as well. So the algorithm is dynamic and it does get revised as needed. Generally about once every 6 months, if not a little less. Let's try to get this page to move. He is sticking. So the key practice changes was the standardized timing, and like I said, old habits die hard. You talk about one of the things that I learned as a new practitioner is that practice creep is creepy practice. And I think that's true for newborn screening. Just because we've done it one way for a long time doesn't make it the right way. We were able to come up with what we thought would be the most universally appropriate time for our babies. It was determined to be date of birth plus 2 between 4 and 7 a.m. I'm going to move over to my cheat sheet here. One of the reasons that we chose this time and what makes this timing so special is that in the NICU we wanted to capture a period before a baby was likely to receive blood products. We wanted to capture a period that was after 24 hours of life. We wanted to also check the box of after some protein exposure. And we also wanted one of the most important things, and I think this resonates with the nursing staff, is that when a baby already is likely to have labs due. This is, just something that really was helpful, and it also helps our staff to remember to draw this lab, because you're looking through your lab slips and you're saying, oh yeah, the newborn screen is due on the date of birth plus 2. So that's something that we hear a lot, which is kind of an easy way to remember it. And then not only is that part of our algorithm and the most simple part, but the procedures for follow-up and follow-through. So let's get that up here. So I broke the document, which is actually just all fitting on one page, into 2 pages so that you guys could read it. And as you can see, the NICU screen is due on baby's date of birth plus 2. As Dr. Moore said, some very smart people still have trouble adding, but we really wanted to make it as simple as possible and make sure that the reasons that a newborn screen would be drawn earlier than that, or less than 24 hours of age in particular, were very clear. And you can see those up there, reasons being transport out of the home hospital, receiving blood, going on ECMO, pre-op, or if death is imminent. If an early screen is obtained at less than 24 hours of life, a baby's screen can be repeated. And this is something that our genetics and metabolic team had wanted us to add. I know that with the addition of additional galactosemia testing, there's some argument that that may or may not be necessary to have any formula or breast milk feeds prior to a screen. But like I said, this is designed specifically for our unit and based on the clinical expertise here at Shore. Here's the pathway that we most recently used to follow up on abnormal or critical newborn screen results. I'm not going to focus too much on this because this is sort of the nitty-gritty of the clinical realm and what our providers use. But as you can see, we do rely on our consultants pretty heavily. I'm here sort of as the kind of in-house NICU consulting party for a lot of the questions that come up. But because we have these guidelines in place, we are able to follow through with any concerns without the, 15-minute belabored perseveration on rounds, which we may or may not come up with the same answer twice. So this has been a really nice change. And I think staff satisfaction, is another aspect that I didn't even think about when we started this, but I think the feedback has been good. So, and this is the last part of the algorithm. It talks about what we do in a case where a repeat newborn screen or a confirmatory or follow-up lab is any of the following: normal, abnormal, or pending. One of our questions that frequently comes up, or that I'm asked, or an attending is asked, is what do we do about this newborn screen? It's abnormal for this, it's abnormal for this. And there are some times where, or it's not back yet. Well, it really depends on the case, but so we chose to use the language that discharge does not necessarily need to be delayed, and these babies need to be, these situations need to be assessed on a case-by-case basis. We have had situations, especially the ones that I can think of are in the hematology realm, where, and sometimes also endocrine, where we're waiting on results for whether it's CAH or repeat on something like that that have been critical, or we're waiting on results for hemoglobinopathy, where our hematology consultant may request that we wait on results before sending baby to community pediatrician. So disseminate and implement. We have to communicate this change in practice to NICU nursing staff and patient care techs, faculty and NPs and fellows, the newborn screening consultants, and the Virginia Department of Health. I'm trying to think if who else is in our metabolic, especially our metabolic screening, metabolic dietitian, Laura Duncan. We had a question and answer period, they email saying, if anyone has questions, please get with me if questions come up. And, we did have a lot of good questions come up. What do we do if a baby has only had one feed? What do we do if a baby has only had trophic feeds? And, it really helped us to suss out some of the details. And then, of course, we had to have a nursing policy to match our protocol. And rollout was September 2012. Evaluation. So initially we focused on timeliness of our newborn screening. And when I say timeliness, I mean our staff being compliant with ordering and to be saying restart required. Okay, not right now. Timeliness of newborn screening, both ordering and with obtaining when the screen is ordered. What are the causes of untimely newborn screens? Well, this seems like a simple question, but it turns out it wasn't at all. Multifactorial, we have early screens that are early not for valid reasons. Ordered too early, late screens can be a missed order, incorrect or no order. Incorrect order, that what we found is that when an order was written incorrectly, it was much, much, much more likely to be missed. So that would make it even a later screen. And then other issues, handling the stranded screen at the bedside that didn't get properly routed to our referrals lab. And so to look at all of this, I developed what I think of as a sort of super techno Excel document, which actually is a very simple Excel document for those that actually use Excel, which is pretty cool. It basically is a way for us to audit the rationale for mistimed screens. It auto-populates based on time of birth and date of birth when the screen would be due. And then it's our newborn screening task force, which is now, we have 3 nurses and 1 patient care tech that help to keep this log up to date. They enter in when the screen was actually obtained, and when it's mistimed, they enter in the rationale. This shared newborn screen data log is password protected, trying to, I want to make sure that I don't have, right, okay. This is further over to the right, it's sort of a very wide document, has an area for fellows to come in and place comments for what a result of the newborn screen was and what was done about it, and to further comment on the date of case closure for the newborn screening. This document is the tool that's used for culling data for our QA/QI meetings, which occur monthly. So how are we doing? Well, it's not that boring. It's definitely not that boring. I just thought this was a funny picture. So when we started this in September 2012, and I will say that it's a little bit confusing because the compliance is better as you go lower, because the y-axis is the percent of mistimed newborn screens. That means that these screens could have been early or late, just to be clear. But we rolled it out in September of 2012, started to audit there in October of 2012, and then by December of 2012, we all seem to have had a, I guess it was just sort of the month that we all forgot, I guess. And then from then on out, we really did have a good steady improvement, and our compliance dropped to within that, around, I think that was around 10% missed time screens. So that's a nice amount of data there. That's a 15-month sample. It says 9 months at the top, but it's actually 15 months, and I didn't get a chance to fix that. That's actually from 2012 to June of 2013. October 2012 to June of 2013. So what's happening, this is a time log also of events. These are actually what occurred at these specific moments, specific dates through time, when we are addressing these issues and wondering, hey, what's going on? We considered missed time screens, these mini critical events, and did inquiries into, what's occurring at the bedside, what's occurring at the cow or the computer where these screens are being ordered, what's occurring that's causing these screens not to be done at the right time. Email to staff, we use an SBAR format. I developed a nursing-specific in-service, which is basically a poster of frequently asked questions, really kind of breaking it down to the more NICU-specific questions that come up. Can you draw newborn screens off of heparinized lines? Do we really need to get a repeat newborn screen if so-and-so? Why do I need to stick the baby for a newborn screen if nothing else is due? Those sorts of things that I think brought, again, that more awareness of the critical aspects of this very time-sensitive lab. And then, of course, there's always the old remind, pester, and as Dr. Moore says, Allie's really great at digging into things, and the old beating everyone on the head, and he says that's really key to really any practice change. And I think, although it may not be the most flattering description, I think you do need to have a passion for any project to move things forward. So here's another more recent example of our improved compliance that I think we were really proud of, and so I did add this slide to show that we had we had every single screen in our NICU timed perfectly in July of last summer, which is really, I think, a really great outcome given the fact that we have such acutely ill patients at times. We have transports, we have babies from other units coming in, we have a very large staff, and we have a rotating resident staff as well. So I think that goes to show what effort this has been. So the newborn screen process changes, what I think of as systems changes, I have outlined below, and this more speaks to some of the things that have happened as we look towards timeliness from bedside to actually getting set up for analysis at the state lab. The referrals lab in 2014, November, began to scan images of newborn screening results into our electronic medical record. That is a huge time saver. Not only that, but basically negates the safety risk of the transcription errors that can occur. As you know, there's a lot of newborn screening results that have to be transcribed by hand if you are doing data entry that way. A lot of room for error. Summer of 2015, our NICU admission orders are revised, and that was my window of opportunity to have timed newborn screening orders pre-populate. This really, I think, was this was really the godsend here, because it's very difficult to mess this part up. We occasionally have some incorrect orders, but these these order slips print out when babies are born, so we never have orders that are, we never have orders that are not fired, at least. We have orders that are missed, but the orders are generated. April of 2016, very recent, yes, we switched to our Virginia State Courier. That has been a very, that's an exciting change for us because we have an additional pickup day. The courier arrives in the evening, except Saturday, and that allows us not to miss a setup time the next morning. What was happening is that our previous courier would, this was an issue with our previous courier because we would just miss that AM or noon setup. I'm probably saying the wrong time, but that's what was happening. But now the screens are arriving and ready for setup in the morning. There's been some workflow changes to our referrals lab. Additional medical technicians there have been trained in the newborn screening process to facilitate that Sunday pickup. So that also involves working, it's really been hospital-wide. I've worked closely with our referrals lab supervisor to help make these changes, and actually she's the one that has, made it, facilitated that change to the state courier. So baby girl repeat, take 2. First screen obtained on date of birth 2, date of birth plus 2, which is abnormal for CAH. We're going to look to our algorithm, and we'll see that, come on now, knowing that the baby's been transfused, what is the provider to do? Well, we're going to look to the algorithm. I'm going to pretend I'm an intern, and I just am really just at a loss here. And it says that this is what I'm supposed to do. So I will order a 17-OHP, and I will order a BMP. I'm going to, examine the baby. Hopefully I'm going to say, she doesn't look virilized, and I feel good about that. I'm going to tell this to the fellow. The fellow is going to see that the 17-OH and the BMP have come back within normal limits. These results are faxed over to Virginia Department of Health, and the folder can be closed. The fellow then sort of closes the loop. I kind of call it, I don't know, everyone calls it a different thing. I like to call it, closing the loop. But the fellow goes back to our shared data log, which is available to the Newborn Screening Task Force, and the second-year fellow who is overseeing this process, and cites the date and that the results were faxed so that there can be no so that we always have that record of that happening, and when there is any concerns about what happened when, we can always go back and take a peek at that and make sure that we followed up appropriately. So when we talk about additional outcomes, these are some of the things that we've talked about. Our state kindly lets us know about number of transfused specimens, and now we are getting quarterly report cards about our transit time. I can tell you, I can be very honest with you and say that Children's Hospital of Richmond has not had the best transit times historically. But between February of this year and May of this year, we introduced the state courier, and our transit time has decreased by 0.75 days. I can also say that in auditing the NICU internal transit time for February, there are only 4 of 32 days that a newborn screen did not go to get processed in our referrals lab for sending on the same shift that it was drawn, meaning the same 8-hour period. So I think that really speaks to just how far we've come. For follow-up, and this is, I know I need to wrap up here because you guys may have questions, but one of the sequelae that have come from this, I think, is when we initially started doing this and looking at timeliness and this case closure, I wasn't exactly sure how it would affect our loss to follow-up. I felt a little bit skeptical at first, and thinking, it was sort of seemingly so many pieces and parts, moving parts to follow in order to get this system almost seemed to be completely revamped. In 2010, we had a 22% follow-up loss for our low birth weight babies. I chose less than or equal to 1,200 grams because it was a pretty good sample size, and this is thanks to Rhonda West, who did some of this data analysis for me at the state lab. And that is, those are babies that we did not officially close the case on. We implemented this protocol, like I said, a rollout in 2012, and our follow-up loss at the Virginia Department of Health for their closing these babies' newborn screening cases dropped to 4% in 2013, 5% in 2014. This is one of the crib cards that the task force developed, reminding staff that my newborn screen is due on the date I'm born +2. That we should not forget that although a lot of times in the NICU we say, oh, these labs are always abnormal, these labs are always abnormal. They are usually, we do see a lot of false positives, and usually they are false positives, but the key word is that it's usually. And I think when we have such a vulnerable population, we can't just try to fit the square peg into the round hole. And we really needed to take the time to sort of look at the newborn screen systematically, break it down, and come up with a solution for our special patients. So thanks so much for listening.
Great. Well, thank you, Allie. As a reminder, if you have questions, please type them into the chat box, and we'll read them off for Allie to respond to. While that's happening, I'll remind everyone that the webinar has been recorded and that once the recording is posted to the NIMAC website and the YouTube page, we will be sending out that link to everyone who registered for this webinar. In addition, please wait until the end of the webinar where you'll be provided with a link to evaluate the presentation you just heard, and we really appreciate you taking a few minutes to do that, as it helps NIMAC improve our educational offerings for all of you. So now, Beth, I don't unfortunately see the question box, I just see the chat box, so you might have to read off the question box.
Okay, yep, I'll go ahead and do that. Thanks, Scott. Okay, we have a question, Allie, that often we experience a trait status that we have reported to the NICU that does not seem to make it to the PCP. The newborn screening program has completed its follow-up by informing the care provider in the NICU of the hemoglobin trait status. Do you have any suggestions from the NICU standpoint as to how that can be transmitted more reliably to the PCP at discharge?
I'm sorry, this is a question about a baby that has a trait for a hemoglobinopathy, and it's a NICU graduate?
Right, yeah, so have a hemoglobin trait and that result doesn't get communicated to the pediatrician after discharge.
Right. So one of the things about hemoglobin traits is that they're not looked at in the same way as an abnormal or presumptive positive result, if that makes sense. And so when we asked about that question with our hematology experts here, I'm sorry, I can't remember offhand with which traits, if it's trait for possible thalassemia or if it's Bart's hemoglobin. Generally, it'll ask for a repeat newborn screen to confirm, and depending on results, there may be a hemoglobin electrophoresis at 2 months of age. Because it's not considered an abnormal, generally what we do is we do rely heavily on handoff from our NICU providers to the community pediatrician in terms of our discharge summaries. The other thing is that we have, in our patient population, in our NICU, we have, I guess it would be the advantage of the vast majority of our patients actually following up here at the Children's Pavilion so that their newborn screening results are actually available to the provider here. But the case of the hemoglobinopathies actually came up as a patient safety event because it used to be that when newborn screening results were transcribed, those did not get bolded in red, and that became an issue, and that actually got changed. So that's a really good question. I'm sorry I don't have a better answer for that, but it came up similarly here.
Okay, another question. Who primarily selects the newborn screening, the lab or nursing staff?
Only our nursing staff.
Another question. Has your facility or the state of Virginia considered recommendation of serial screening, also known as the CLSI guidelines for low birth weight infants, in an effort to help reduce false positives and extra diagnostic lab orders?
Yes, we, and I know I had to fly through some of the slides, but that was one of the pieces of literature that we looked at, courtesy of our metabolic dietitian who actually had that document. The CLSI guidelines for sick and preterm infants, one of the newborn screen timings for that is actually on admission. What we knew is that if in our unit, if we did that, we would immediately be not in line with what our state was recommending. Now, that doesn't mean that wasn't the only reason we didn't do it. We also felt like it may not be, it didn't seem at the time to be necessarily the best way to avoid false positives. The timing that we use in general, our babies have been exposed to TPN, however, and what we were hoping at the time is that they had been exposed to only a few hours of TPN for the vast majority of our patient population based on birth weight, and that would reduce our false positives for some of the amino acidopathies. So we did think a lot about reducing false positives and ways to do that, but you know, we knew just right off the bat that getting a newborn screen on admission was, you knew that you would have a lot of skewed results there as well. Or that was the feeling of the expert consultants at the time.
Just a reminder to everybody, we'll give one last chance for questions. I don't see any others, but you can use the chat box or the questions box to type in your questions.
I did want to add, Beth, that if I could, that we did discuss briefly the CLSI guidelines at the state level at a Genetics Advisory Council meeting in 2013, I believe. And started a conversation about that. I know that there are regions of the United States that use that, and I feel like that it's certainly I certainly think that it's a much safer practice than having no systematic protocol in place.
Great, thank you. That's helpful. Okay. So it looks like we have just a comment that the CLSI guidelines were revised and they'll be published shortly, and that the new guidelines allow for more flexibility in timing, as a lot of institutions are also not comfortable with an admission screen. So certainly we'll watch for those new guidelines to come out, and that's something that NIMAC can alert people to as well when those new guidelines are available.
That is really interesting, and I appreciate that. I really have relied on some colleagues for information from CLSI because it's not a document that I, you know, as a clinician, sort of was privy to before getting interested in this research. Meaning it's not something like a white statement or an AAP guideline that's, you know, easily accessible to interested or stakeholders. It's something that, you know, maybe, you know, a couple $100 and, you know, units in community hospitals and smaller NICUs, it may be a little bit more difficult to access.
Great, thank you. Well, Scott, I don't see any other questions if you want to go ahead and wrap up.
All right, great. So I want to thank Ali again for a wonderful presentation, and I want to thank all of you viewing the webinar for spending the last hour with us. I'd like to remind everyone that the next webinar in the NIMAC Timeliness series will be in 2 weeks on Wednesday, July 27th, again at 12 p.m. Eastern Time. And that webinar will cover the next step in newborn screening process, which is analytic timeliness in newborn screening. And it's going to be co-presented by me, Dr. Scott Schoen from New Jersey, and the director of the New York Newborn Screening Program, Dr. Michelle Kajana. Thank you again, and at the end of the webinar, please follow the link for the evaluation, and everybody have a great day.